Good morning and welcome to day 2 of the 2025 APAICS Health Summit. I'm Marilyn Milka, President and CEO of APAICS, and I'm looking forward to continuing our conversations on health disparities, access, and the future of healthcare for AA and NHPI communities. A special thanks to our summit partners, Adtalem, Amgen, AstraZeneca, Biogen, Blue Cross Blue Shield, Catholic Health Association, Compassion and Choices, Pharma, and Planned Parenthood for making these discussions possible. I am now honored to introduce CAPAC Executive Member Congresswoman Marilyn Strickland, who represents Washington's 10th District. Congresswoman Strickland is an advocate for equitable healthcare access, ensuring that every American, especially those from underserved communities, has access to affordable, high-quality care. Please join me in welcoming Congresswoman Strickland.
Greetings, everyone. I'm happy to welcome you all to the 2025 Health Summit. Thank you, APAICS, for inviting me to share my thoughts. As many of you know, we often hear about the model minority myth. It's a harmful stereotype that diminishes the complex issues that our communities face. It also lumps our identities into one, something that is especially apparent when it comes to our healthcare system. For example, as a member of the Congressional Diabetes Caucus, I know that some Pacific Islander communities face alarmingly high rates of obesity, diabetes, and heart disease. Unfortunately, disparities like these are overshadowed by generalizations about the entire AA-NHPI population. We are, in fact, a diverse group of people with cultures and heritages and food from around the world. We deserve a healthcare system that recognizes this. Yet medical research and public health in the United States continue to group us all into one single category. And that's why today's panel discussion is so important. We must continue working together across government agencies, community organizations, and healthcare providers. And we must empower our communities to make good choices that lead to longer, healthier, and happier lives. I hope you enjoy today's summit and the upcoming panelists. And I thank you all so much for being here today.
I am now pleased to introduce CAPAC Associate Member Congresswoman Lucy McBath, who represents Georgia's 6th District. A fierce advocate for health equity, Congresswoman McBath focuses on improving healthcare access, reducing prescription drug costs, and supporting marginalized communities. Please join me in welcoming Congresswoman McBath to the Health Summit.
Hi, my name is Congresswoman Lucy McBath, and I represent Metro Atlanta in the House of Representatives. In my time in Congress, I'm proud to have represented one of America's largest AAPI communities. I want to thank the Board of Directors of the Asian Pacific American Institute for Congressional Studies for inviting me to speak and express my gratitude to our attendees for joining in this programming. To make sure that AAPI culture is thriving in Georgia, we must set the foundation of healthy communities that grow into a rich and diverse tapestry of cultural and faith-based traditions that open their homes, houses of worship, and businesses for all Americans to participate in. I am a 2-time breast cancer survivor, so I know that it's critically important to study and properly understand health disparities. If we want to improve health outcomes for everyone, we need our health system to work for everyone. I am proud to fight against health disparities in Congress, and I appreciate all the work that you have done to highlight this issue. The conversations at the summit are just one part of a national movement to save American lives. As we look to solve these large healthcare issues, we cannot forget the forces that seek to divide us as Americans. We cannot forget dangerous rhetoric and what it seeks to incite if we fail to act proactively. We must protect our neighbors as we build bonds as fellow Americans. I'm proud to do my part for our communities in Congress, and I keep my heart close to the AAPI community. I look forward to the incredible discussions and dialogue that will happen here today and shape the world of tomorrow. Thank you for all of the important work that you are doing. God bless.
Our next Health Summit panel is Interpreting Health disparities through disaggregated data. The AA and NHPI community spans over 50 countries, 100 plus languages, and 60% of the world's population. Yet in US research and public health, they are often grouped into a single category, masking critical disparities. This panel will explore the impact of that invisibility. Next, I am pleased to introduce CAPAC Chair Emerita, Congresswoman Judy Chu. Congresswoman Chu represents California's 28th district and advocates for healthcare access and equity. She has been instrumental in pushing for disaggregated data collection to better understand the unique health needs of the Asian American, Native Hawaiian, and Pacific Islander communities. Her work helps bring visibility to health disparities that have long been overlooked. Please join me in welcoming Congresswoman Chu to the APAICS Health Summit.
Hello, I'm Congressmember Judy Chu from California's 28th District. Thank you all for joining this APAICS Health Summit to better understand the unique challenges that AA and HPI communities face in accessing healthcare. I'm so glad that we have this opportunity to come together and discuss how we can further disaggregate data to tackle health disparities. I especially want to thank APAICS fearless leader, Marilyn Strickland, the entire APAICS team, and all the sponsors represented here today who make APAICS' many phenomenal programs possible. AA and HPI communities are impacted by a number of health disparities. For example, Asian Americans comprise 7% of the U.S. population, but suffer 60% of chronic hepatitis B cases. And while Asian Americans overall have lower cancer rates and mortality than the general population, we have the highest rates of stomach cancer, around double those of white Americans. Part of the explanation for these disparities is that our community has a more difficult time accessing quality healthcare due to language, cultural, and geographic barriers. With 32% of our community having limited English proficiency, many AA and HPIs face barriers to accessing life-saving information and care because much of this information isn't widely available in AA and HPI languages. Complicating matters, far too often, AA and HPIs, made of over 70 different racial or ethnic groups, speak over 100 different languages and are lumped together in data sets broken down by racial demographics or worse, excluded entirely. That means we can't determine whether disparities exist between AA and HPIs and other racial and ethnic groups or whether disparities exist within the AA and HPI community itself. Without data disaggregated within our community, problems for certain subgroups can go largely unreported and unaddressed. But disaggregating that data means that we can tailor policies and outreach to the needs of individual AA and HPI subgroups. That's why I was thrilled that under the Biden-Harris administration, the Office of Management and Budget revised the federal minimum standards for race and ethnicity data for the first time since 1997. Updates that I advocated for as the chair of the Congressional Asian Pacific American Caucus, or CAPAC. This announcement was no minor bureaucratic change or maneuver. It's a once-in-a-lifetime generation breakthrough for our communities. If implemented, these changes will increase data collection and disaggregation across all the federal government, including in the U.S. Census, improving the ability of federal programs and services to serve the needs of AA and HPI communities and other communities of color. These changes are critical in our fight to end health disparities. With disaggregated data, our healthcare systems will be better equipped to identify, test for, and treat diseases like hepatitis B and stomach cancer. It will also help raise awareness about these diseases so that people in our communities can take preventative action and get connected to the care they need. This is so important because while both hepatitis B and stomach cancer are treatable when diagnosed early on, many people dismiss early symptoms because they are unaware of their heightened risk. And while we've made significant progress on lowering rates of hepatitis B through the CDC's Division of Viral Hepatitis, stomach cancer has gone largely unaddressed despite its overwhelmingly disproportionate impact on Asian Americans. That's why I soon will be introducing the Stomach Cancer Prevention and Early Detection Act, which would direct the National Cancer Institute to review the state of stomach cancer in the U.S. and provide recommendations for prevention and early detection, which is essential in tackling this disease. While our path forward under the current administration will be challenging, we must continue to fight for the visibility of all our AA-NHPI community members and work together to ensure that there is strong, consistent, and coordinated progress in data disaggregation to fight health disparities across all agencies. And that's why I'm so glad that APAICS is hosting today's panel to shine a light on interpreting health disparities through disaggregated data. I want to thank your moderator, Dr. Latha Palaniappan, and your panelists, Erin Henderson, Samira Khan, Joshua Ang Price, Suzanna Tiapula, and Isha Weerasinghe, for sharing their expertise and guidance to uplift our communities. Thank you.
I now invite you to join me in welcoming KPAC First Vice Chair, Congressman Mark Takano, who represents California's 39th District. A strong advocate for racial health equity, Congressman Takano works to secure funding for local health projects, including behavioral health centers and youth recovery programs, to address the growing need for mental health services in underserved communities. Please join me in welcoming Congressman Takano.
Hello, I'm Congressman Mark Takano, and I have the honor of serving as KPAC's first Vice Chair. I'm grateful to have the chance to talk to you all and prime your discussion on the importance of disaggregated data on health outcomes in the AA-NHPI community. As you all know, the AA-NHPI community faces unique challenges in receiving health care, from language barriers to long-standing bias about receiving mental health care. Our community requires direct and thoughtful support. The Biden administration took historic steps to expand and build capacity for disaggregated data to ensure that the vast communities, cultures, and experiences are reflected in data. President Biden directed the Office of Management and Budget to revise the standards for maintaining, collecting, and presenting federal data on race and ethnicity for the first time in 27 years, helping ensure that AA-NHPI individuals can more fully self-identify by specific ethnicity. Now, our community is not a monolith, so data in health outcomes, home ownership rates, degree attainment, and economic prosperity should reflect our community's diversity. Broadening these demographic categories is the first step in crafting good legislation to address the needs of AA-NHPI communities. Without it, legislators are in the dark. To attack the problem, we need to understand the problem. I'm deeply frustrated that the Trump administration has attacked these efforts as being divisive or exclusionary. We have a lot of work ahead of us to ensure the momentum of gathering more complete data can continue. It'll give us the best, most complete picture of where our communities fall in comparison with the rest of the country. You stand as champions for data equity, and I thank you for your commitment to the AA-NHPI community. I wish you an enriching discussion and hope the lessons learned can be shared among APAICS, KPAC, and the broader AA-NHPI community. Thank you.
Now, I'm pleased to introduce our moderator, Dr. Latha Palaniappan, an internist and clinical researcher dedicated to chronic disease prevention and health equity. She co-directs the Stanford Biobank and co-founded Stanford Care. A Fulbright Future Scholar, she has led research collaborations across Australia and Asia. Please give her and our panelists a warm welcome.
Thank you for the opening remarks, President Melky, Representative Takano, and Representative Chu. I'm delighted to join you all today on this panel. My name is Latha Palaniappan. I'm Professor of Medicine at Stanford and Associate Dean of Research. I am delighted to be joined today by our esteemed panelists, Samir Khan, Suzanna Tiapula, Erin Henderson Lacerdo, Joshua Ong Price, Isha Weerasinghe. Thank you all for joining us today and offering your diverse, unique perspectives on AANHPI health. I would like you each to introduce yourselves and then we'll get right into the questions. Samira, can we start with you?
Sure, thank you. Hi, everyone. My name is Samira Khan, and I serve as the president of the South Asian Public Health Association, also known as SAPA. We are a national nonprofit that's dedicated to improving the health and well-being of South Asian communities in the U.S. My background is in public health research and health equity, and I also lead clinical and research initiatives in pulmonary and sleep medicine at Mount Sinai. At SAPA, we work to improve health outcomes for South Asians through research, education, advocacy, and collaborations. One of our key focus areas is data disaggregation, because without accurate and detailed data, the health disparities in our communities remain invisible. SAPA has been working on this issue through research projects and developing research resources. For example, we just launched a research hub on our website, which is essentially the equivalent of a South Asian PubMed, to better enable researchers to find information on South Asian health disparities. We also collaborate with universities on grants. For example, the collaborative approach for ANHPI research and education, or the CARE 2.0 study, which looks at aging and Alzheimer's disease and caregiving in the ANHPI population. We also lead our own projects. For example, projects look at health misinformation and uplift other researchers on the work that they're doing. And we're also constantly working throughout the year to put out social media campaigns, fact sheets, webinars, and toolkits that's dedicated to advocating for South Asian health priorities and highlighting the work that's been done in the respective areas that we focus on. Thanks.
Wonderful. Thank you, Samira. Suzanna?
Aloha. Good morning. I am based right now in Hawaii, and I would like to honor and thank the indigenous people of the land where I am based. I am born and raised in American Samoa. I currently serve as an attorney for local communities. My background is in justice and its intersection with health in our outreach to communities. I am here today representing Compassion and Choices. Compassion and Choices tries to access Pacific Island communities, Native Hawaiian communities, and identify strategies for accessing health and end-of-life resources. We look at how to work with diaspora communities, and we do a lot of our outreach through art, and I'm really excited about talking about that. Thank you, Latha.
Thank you, Suzanna. Erin?
I'm Erin Henderson Lacerdo. I'm an LCSW, born and raised here in Hawaii, and also Native Hawaiian. I'm serving as Executive Director for the Association for Infant Mental Health in Hawaii, and we focus on workforce development, specifically for mental health professionals in the prenatal to 5 arena. One of our priorities is to work toward a workforce that is representative of the community they serve, which also means supporting culturally responsive frameworks and methods that are relevant and effective with our diverse community. I also am a proud member of the board of the National Asian Pacific Islander Mental Health Association. Glad to be here. Mahalo.
Wonderful, Erin. Thank you. Joshua?
Good morning, everyone. Mabuhay. My name is Joshua Ong Price, and I am the CEO of Hybrid Strategies. We are a consulting firm that works with government agencies as well as nonprofits on community projects, fundraising, as well as policy, especially policy that affect our Asian American, Native Hawaiian, and Pacific Islander communities. I am also a board member of the National Asian American Pacific Islander Mental Health Association, and I formerly worked for the federal government for about 10 years, specifically with the Delta Regional Authority, which covers 10 states in the Mississippi Delta region, as well as the U.S. Small Business Administration. So in those roles, I worked with outreach, communication, and especially trying to reach those AANHPI and other minority groups. I'm also a co-founder of Tayo Help Desk, which is a program of the Filipino Young Leaders Program. We launched that in 2020 in response to the pandemic to make sure that we had trusted information that was being given to our Filipino American seniors, elders, and frontline workers to make sure they could navigate the pandemic, especially around PPE and also how to access business loans for their small businesses and their voting rights as well. Thank you so much for having me today.
Thank you, Joshua. Isha?
Hi, everyone. I'm Isha Weerasinghe. I use she, her pronouns. I work at CLASP, the Center for Law and Social Policy, and I'm the Associate Director of Mental Health and Wellbeing. I'm at CLASP. CLASP is an anti-poverty policy and advocacy organization. We work on the national level and state and local levels, depending on the partners we have the pleasure of working with. And our policy issues and perspectives all center racial equity So data disaggregation and learning from what communities are experiencing are really key to our work, especially learning from lived experience. My career has always been in health equity, and I spent the past decade prior to class working in Asian American, Native Hawaiian, and Pacific Islander health. I'm happy to be here.
Thank you, Isha. And thank you to the Asian Pacific American Institute for Congressional Studies for assembling this amazing panel. I'm really looking forward to our time together. So the first question I have for all of you are, what are the challenges that you have in your work? How does your work impact AA and HPI communities and other specific communities? I wonder if panelists would like to comment.
I can start. So data disaggregation is, very critical to the work that we do because AMHPI communities are not a monolith. There are over 50 ethnicities, over 100 plus languages, yet we're often grouped into a single category, which leads to erased disparities, misinformed policies, and under-resourced health interventions. Also leads to misdiagnosed conditions, inadequate research funding, and policy decisions that don't really reflect our needs. So for example, South Asians have among the highest rate of heart disease and type 2 diabetes globally, often at a lower BMI threshold. Yet aggregated data often masks these risks, resulting in delayed screenings, misinformed provider guidelines, and a lack of culturally tailored interventions. In the mental health landscape, mental health outcomes differ widely across AMHPI subgroups, but many studies fail to capture this nuance due to the lack of disaggregated data. Stigma is very prevalent around mental health in the South Asian culture, and symptoms often manifest as physical symptoms, which leads to underdiagnosis. But without detailed data, policymakers and healthcare systems fail to recognize the severity of things like depression, suicide risk, and barriers to accessing culturally competent care. So a population that's already lacking resources is going to be further disenfranchised from those resources. The lack of this available data will lead to, policymakers, researchers, and healthcare providers not having the necessary information to address the needs of our communities effectively, which means that, public health funding might be misallocated, reinforcing some of these inequities. Medical research won't reflect a lot of our unique risks, leading to ineffective interventions. And then language and cultural barriers won't be addressed either because policies won't recognize the specific needs of each of these subgroups that exist. And so a lot of these interventions that are being put out there and that are being funded are all essentially going to overlook most of those that are at risk. And so, at SAFA, we are really trying to advocate for better data disaggregation to overcome some of these challenges. Thank you, Latha.
Thank you for the opportunity to address some of the barriers. I'm just going to focus on two. First, I'm going to start with nomenclature. When we ask for disaggregated data, what we're asking for is that the individual populations be addressed as individual populations. I've never met a Native Hawaiian who introduced themselves as NH, ever. I don't self-identify as PI. When I forward emails, information announcements to partners in the Pacific region, I have to tell people that they are the population intended when the email's labeled grant funding AA, NHPI. And it gets even more interesting because sometimes they add on ME for Middle Eastern. It's basically the government identifying a group and not bothering to identify who we are. So when we ask for disaggregated data, if we can't be bothered to disaggregate who we are, I don't know why anyone else would either. So I just ask that we really think about when we're asking for disaggregated data and when we're speaking to people, speaking to them where they are and recognizing that no one in the Pacific self-identifies as PI. So I ask for the honor of my identity. I'm a Samoan woman, very proud Samoan woman. The second issue is diaspora communities are Pacific and we cross jurisdictional boundaries. So medical outreach, mental health outreach, public health outreach, our families live in different countries. American Samoa and Western Samoa are divided by 80 miles. I have family on both sides. Everyone does. A grandmother on one side, cousins on the other side. When a woman in American Samoa is being abused, her brother is a businessman in Southern California and several of her children live in Oregon and Washington. When they reach out to their domestic violence support network, the support structures are often bounded by the political funding entity, and that's usually jurisdictional. If you're lucky, it's at the state level. It's often smaller. Oakland. I can work with you for people in Oakland. Our diaspora communities span the world. So the outreach has to recognize where we are as a diaspora community and look at the fact that the Marshallese community, and we have people on the panel with expertise, are spread throughout different communities in the United States, both in Utah and Arkansas, in the Marshall Islands. With climate change, we're going to see that replicated. Thank you.
Mahalo, Suzanna, for your comments. I really appreciate hearing what you have to say, especially in regards to the diaspora community. And that's related to some of the points that I'd like to share today as well. One is really around historical context, and secondly, recognizing the impact of social determinants of health. So one thing I'd like to share is how Native Hawaiian history is different from many of the ethnicities in the AANHPI category, and that we have a homeland that is now owned by another country, and colonialism is very alive and very well today in our communities. This disconnection to land, to our culture, to our language is a systemic disruption in our health. So in many ways, our history is more akin to Native Americans, and being lumped together with other groups do not give us a chance to understand health and mental health outcomes that are specific to us. Secondly, we talk a lot about health, but we don't talk enough about mental health. And adverse childhood experiences, or ACEs, are critical to understanding how early experiences impact a person over their lifetime. Research on Caucasian middle-class participants show that approximately 2/3 of the United States has at least one ACE. And an NIH study done recently in Hawaii with the disaggregation of ethnicities showed that while residents of Hawaii had a lower rate of ACEs in the nation, around 60%, as opposed to the national 66, Native Hawaiians had at least 75% of the Native Hawaiians studied had at least one ACE. Conversely, Japanese, Chinese, and Filipinos in Hawaii had a range of one ACE at about 40 to 52%. That is a 25 to 35% difference within the groups of the AANHPI category, and a disparity that we wouldn't recognize if we had asked the same question at a larger categorical level. This may explain some of the data that we see that demonstrates that Native Hawaiians are overrepresented in Hawaii's judicial and child welfare systems. And for those reasons, I do find it imperative that we consider how the disaggregation of data can impact the health of a community.
Just to add to the great comments that were made already, I think it's very important in data collection to be in light of especially what Erin and Suzanna were saying, to be very thoughtful about how data is collected, and to see when you're filling out surveys, that you see yourself reflected in the surveys, that you feel trust to be able to fill them out. I will say I come from the Sri Lankan community. Many of my community members don't see themselves in data and will actually maybe misrepresent who they are by checking Asian Indian instead of Sri Lankan. So our communities are not represented at all within data sets. And then from a larger perspective, which Samira painted such a great picture of, like, what were really the challenges that we're seeing overall. The masking of data really masks what social and structural causes are of health inequities and health disparities. And also from my perspective, from the mental health perspective, without being able to have disaggregated data, you can't ask for resources. And that is not only from the public side, but also from the private side. You can't make the case for it. In mental health, there was a great study called the National Latino and Asian American Study that did have some disaggregated categories, but the funding was only for a short period of time. It was done over 20 years ago. And without more funding to be able to do that study in more languages across more regions, we have some great examples that exist, but we can't do more without more resources. So thank you.
Thank you, Isha, Samira, Erin, and Suzanna, for so eloquently describing the challenges that are facing our communities. I wonder if I could ask our panel, what are some potential solutions?
Yeah, Latha, thank you for that question. Just hearing what everyone is saying about the importance of disaggregated data, I actually have an example. So I am a Chinese Filipino, or we also call ourselves Chinoy. Those are folks who are either full Chinese or partially Chinese, but grew up living in Philippine culture. My mother, being Filipino, she is prone to gout. I actually got gout for the first time in 2023, and I had no idea what was going on. But something that's commonly prescribed for people with gout in the United States is allopurinol. So my mother was prescribed allopurinol, and she actually had a severe reaction. She got Stevens-Johnson syndrome, which is a severe skin reaction, to the point where she was hospitalized, and it was touch and go for a minute there. But if this data were to be disaggregated, and if medical care providers and mental health providers knew what kind of medications and interactions were prevalent in different communities, we could avoid those issues. So colchicine is something that was then prescribed to me and was prescribed to my mother. In fact, I went to the Philippines recently, and colchicine is available over the counter because it's so common. Gout is such a common issue in Filipino communities, and they don't prescribe allopurinol in the Philippines at all because there's such a high rate of that allergic reaction. So again, just having this disaggregated data and being able to disseminate that information to our medical care providers, that can make a huge difference in the lives of AA and HPI folks that are going to these medical providers for treatment.
So I'll just add from a federal perspective and then some of my own perspectives working with communities. So from the federal perspective, last year, the Office of Management and Budget, OMB, made changes to the Statistical Policy Directive, SBD 15. And with that, they added the MENA category, Middle Eastern and North African, but they also standardized how race and ethnicity would be categorized. I think from our perspectives on the panel, it's not enough, but it is a start. And so the directive is for federal agencies to collect that kind of data, at least, and be more descriptive. And in the essence of time, I was going to explain what they look like, but they are more descriptive than they were in the past. And then we have standards like Section 4302, which is part of the Affordable Care Act that was implemented in 2010. That does include more specific categories under Asian American and Pacific Islander. Again, we have done advocacy over the past 15 years to make those categories more disaggregated, but it is the start. I would say from my perspective, from the community angle, community-based organizations and FQHCs, federally qualified health centers, community health centers, they collect a lot of rich data. The FQHCs have a data set called the Uniform Data Set that they are able to collect primary language and data by race and ethnicity and share with each other. And I think it's imperative for there to be more data sharing agreements to be able to share this rich data within our communities to be able to better serve our communities when we feel like the federal data sets aren't meeting our needs. Thank you.
Thank you. And that insight is invaluable. The sharing of data is critical. I'd also encourage medical professionals, medical institutions, scholars to reach out to the nonprofit sector. And I'm going to give you a few examples. In Compassion and Choices, we have a geospatial mapping of Pacific Island peoples across the Pacific in the United States, and it's temporal. So I can tell you that the population on the coasts have dropped, with many of our peoples moving inland, probably due to the cost of living. But we actually track where peoples move. My communities are smaller. It's very expensive to disaggregate the data. But if you're working with nonprofit communities, we can tell you where we are. We work with arts partners on listservs, and we have them tailored to not just the individual nation states of the Pacific, which were divided colonially. So you have a single people, the Samoas, that are two different countries. You have many different communities in Micronesia that are lumped together into single states, single countries that have really no historical relationship with each other. So the individual peoples of the Pacific region have built platforms, social media platforms. They have networks where they communicate, and we try to support them. During the COVID epidemic in Australia and New Zealand, they identified Pacific Island peoples as very, very resistant to discussion of vaccine. They reached out at that point to the Pacific Indigenous Women's Network. And for the better part of 2 years, there were probably 50 to 150 of us who were facilitating conversations in faith communities, evangelical communities, traditional networks, trying to talk about medical responses, vaccines, and outgrowth of that is an effort to build scientific literacy. If my community doesn't have scientific literacy, just basic science and math, they're choosing the person they like the most when they accept data. And we're trying to work towards scientific literacy. We use arts to access the community. It's less threatening, and we need to have these hard conversations about health. So we really encourage you to work with your nonprofit communities. We're already there. We're already working. We have access to the populations that you're trying to work with. Please reach out to us. Thank you.
Thank you, Suzanna and Isha and Joshua, for those inspiring potential solutions. I wonder if I could ask the panel, what can our community be excited about as we look to the future?
It's a great question, Latha. I think just given the current climate, even in the face of policy rollbacks and anti-DEI rhetoric, there's still momentum and grassroots power in communities that gives us hope. So, for example, community-led research and advocacy is growing. Even though there might not be a focus on the federal level to fund research that looks at disaggregated data or that looks at specific ANHPI populations, there is a lot of momentum still within researchers and academia with studies that are being led to look at these populations. And I think currently we have a lot of philanthropical organizations, foundations stepping up to the moment to really fund some of these initiatives. And then, even on an organizational level, SAFA itself is working to highlight some of the nuances that comes when it comes to taking care of a South Asian patient. We're developing a guide that we would hope to share with providers on what it means to have a South Asian patient, what are the specific needs of the South Asian patient. We've developed a health disparities report that we're hoping to launch soon. And a lot of this is utilizing the data that's available, but we're hoping to use it as a tool to also advocate for more data disaggregation. And then a lot of community-based organizations are also getting involved in research, which is nice to see because you have academia partnering with the people that are on the ground. And so you don't have outsiders coming into communities to collect this data. You also see a lot of people from within the communities that are going into research, into public health, into policy. And so a lot of this change and advocacy for the community is happening from within the community. And so we are hoping to see a lot more of that partnership in the future. And then also on the state level, there are states that are pushing for data disaggregation. States like California, Washington have passed data disaggregation laws, which creates models that we can advocate for in other states. And at SAFA, we have been focusing on looking at South Asian enclaves. And a lot of these enclaves are in areas that do have great data disaggregation. And we're hoping to use that as a model to advocate for more of that across the country. And then I think there's also just a lot more public awareness and advocacy on social media. There is more demand for data disaggregation. There's more coalition building. And so, we are here to really make some of that noise to push for it. And regardless of what's happening at the federal level, there has been a lot of momentum at the organizational level, at the institutional level, and state level.
Wonderful. Thank you, Samira.
Yeah, I agree with Samira 100%. The organization I mentioned earlier, the Filipino Young Leaders Program, when we launched our Tayo Help Desk in 2020, that was directly in response to the pandemic because we weren't getting the response from government that we needed. So Filipino nurses make up about 4% of all nurses in the United States, but accounted for 33% of the deaths. So you're talking about 1/3 of nurses who passed away from COVID were from our community. And that was really a shocking number. And so we thought as young leaders, we need to do something about this. And that's why we launched Tayo Help Desk. So now that we're kind of post-pandemic, we've worked with different universities, we've worked with different federal and state agencies on helping disaggregate some of this data by collecting data specific to Filipino American communities. And another thing I wanted to mention, somebody mentioned it earlier in the panel, but just making sure that our communities are checking the right box. A lot of Filipino Americans will sometimes check Pacific Islander because they think it's an island in the Pacific. But working with some of my Marshallese colleagues in Arkansas, they told me, hey, don't tell the Filipino community not to check Pacific Islander because there's over 4 million Filipino Americans in the United States. And if they start checking Pacific Islander, they'll actually skew that data away from the group that it was intended for, which is the Marshallese, the Samoans, the Native Hawaiians, etc. So again, those community partnerships, I think, are very, very important moving forward to make sure we're collaborating and we're also collecting the data in an accurate way.
Thank you. Next, I want to move to a call to action for all of our listeners today. What can we do to make sure that our community is not left behind as we move forward?
I would really like to echo the comments that were just shared from many of the panelists around the data boxes and being able to help the people answering the questions to see themselves in the data. I, for example, don't always know how to answer because I am Native Hawaiian, yes, and I'm also Japanese, and I'm also Caucasian. So when I go to answer surveys or data questions, sometimes I have to ask myself, who am I today? And which box am I going to check? And in what way do I want people like me represented? And so in that vein, I'm hoping that we can truly find a way to help our data sets be more reflective of the community so that the people who are responding actually identify themselves to be in the boxes that they are kind of set out to name. One of the other points I'd like to make is that workforce development is really critical in rising up leaders and providers who are reflective of the community. And they would have insight like that, similar to what many of the other panelists have shared, of these stories of how the data impacts the community. And then if the community is able to lead, they can be able to be a part of the solution and provide ways in which the communities can thrive. I'd also like to add that it's important to not leave out the qualitative data. We've talked a lot about quantitative data, statistics, but many of our cultures actually live in the qualitative world, in the world of mo'olelo or stories, in communicating through oral histories. And a lot of the data that we talk about is defined through a westernized lens and can actually miss quite a lot of the high quality things that communities know about for themselves. So it's really imperative that we don't aggregate data to make things more convenient for ourselves, but to make it more representative of who we're trying to support and serve.
Yeah, I want to echo Erin's statement as someone who's also a mixed ethnicity. When I get any kind of survey that I can check multiple boxes, I'm so happy. But when you can only check one box, or if the box says mixed race or other, like I feel like that's just a death sentence for data. I mean, what is two or more races or other? What is that telling you? It's not telling anybody anything. I mean, it's basically like just a catch-all, and I feel like that's probably like one of the worst answers I've ever seen, on a survey that someone can choose. Another thing I wanted to touch on, so a community organization like Tayo that I'm working with, we're doing direct outreach to our communities. The same with NAAPIMHA, trainings, info sessions, educating our communities so they know not only what boxes to choose, how to make sure that their data is collected in the correct way, demographically, and then also making sure that the issues affecting our communities are highlighted. So I want to give another personal example, and I love that you mentioned about storytelling, because we have that in the Filipino community too. It's called kwentuhan. But my mother, who I mentioned previously, she actually had COVID in 2022 and suffered from a stroke, an ischemic stroke. So she's doing better now. However, the stroke occurred in part of the language center of her brain, but I noticed when I would visit her at the hospital, she switched to speaking only Tagalog. And I said, what is going on? Like, we never spoke Tagalog in the house. We actually spoke Bisaya, or Ilonggo was our local language, or English. So I was thinking, why is she speaking Tagalog? Well, come to find out, all of her nurses were Filipino, and they had been speaking to her in Tagalog, so she started picking up speaking Tagalog. But there's very little data on stroke patients who are also multilingual, because again, the data is skewed toward white men. So it was actually her ability to be multilingual which saved her language center, and she's now a lot better, and she's speaking all three languages fluently again. But a lot of our community are multilingual, and where's the data out there that's addressing that, especially with these kind of issues like stroke or any kind of neurological issues. So I do have hope for the future, and I think our communities cannot be left behind by really just empowering ourselves, educating ourselves, like you said, making sure we're choosing the right box, making sure we have our workforce development and our education. Again, Tayo, we're actually going to have a gout webinar just to educate our communities about gout, because it's such a systemic issue in our communities.
I just want to add, I love those comments. And I think it's really imperative, even with, as Samira was talking about the attacks on DEI, on HHS, that it's really imperative that we really hold the line. We have been doing this advocacy through all administrations, at least since I started working in federal advocacy about 15 years ago. So it doesn't matter who's at the helm. This has always been a central issue for our communities. But it is very important that we need to hold the line now. Also, I just wanted to echo Erin's point about qualitative data and the importance of that. I think I completely agree that it is not celebrated and acknowledged as much as quantitative data is, probably because of inability to make things very neat. But it does provide such incredible insights. From the class perspective, we started doing some qualitative data gathering through focus groups to learn more from immigrant communities about perspectives of mental health, and tying that to policy. We started working with Bangladeshi immigrants, and then hope to work with other communities as well, and really believe that it's very, very important. But in terms of, looking to the future, I think what is very important is to organize. Everyone on this panel has been talking about the community, the rich community level data that exists. We need to work with each other to share, to be open to sharing, because we're the ones who are going to be able to change the narrative, and we have to do this ourselves. One thing that I think is also very important in us organizing and sharing ourselves is also the data privacy issues. I think that also always becomes an issue with data sharing, but if we have proper data sharing agreements and know that data privacy is going to be a huge issue on the federal side, we can at least protect our data within communities. So a little bit of a caution and a hope in my response. Thank you.
Great. I want to take a moment to thank the wonderful panel that we have assembled today. Thank you, Suzanna, Joshua, Erin, Isha, and Samira. I know that we have talked before. Many of you are doing the work that you are doing as a calling and not as a vocation. And I know we've talked before. And I invite our listeners to reach out to any of the people on this panel because they have invited collaboration. So easily findable through Google. I will take the moderator's prerogative for a moment and say that I am so grateful for your work as a physician because as your doctors, we are flying blind in taking care of Asian American, Native Hawaiian, Pacific Islander populations. And I apologize for sort of using that acronym and categorizing, and I've been educated on this panel today to do better as we take care of patients, as we describe our patients in our medical records and our research. I will just state for a moment, because of this frustration with lack of guidance for AA and HPI populations, we founded at Stanford, the Stanford Center for Asian Health Research and Education. CARE is what it's called. We have noted, as you have, that AA and HPI populations make up over 60% of the world, and yet only make up 8% of our genetic databases, 10% of our clinical trials. So we have a long way to go to create precision health for AA and HPI populations. And I have done my best in my 25 years of NIH-funded research to disaggregate AA and HPI populations and have found all of the differences that you are stating. I do pharmacogenomics as part of my clinical work, and I use that allopurinol example often. Joshua and Samira, the work that you have cited in disaggregating South Asian groups in particular, I have been sort of part of that fight. So thank you all for continuing to move this field forward. And thank you all for your comments on multiracial populations. And we have advocated as much as we can in electronic health records for being able to check at least 6 boxes, in terms of the boxes and encouraging people to write in, for instance, Taiwanese, and, great example was Sri Lanka and Isha. So thank you for encouraging people to write in, and Suzanna, you mentioned this as well. So please write in how you would like to be identified as we move forward, and that helps us learn as we are looking at the data and thinking about how to move research forward. I will also just state the little bit of research that we've done in Hawaii and California has shown that multiracial populations are at particularly high risk for cardiovascular disease and diabetes. So these are areas where we need more research. And I like your idea, Suzanna, of working with nonprofits to sort of be able to expand just our power to look at specific populations that are at high risk. So I will close by thanking APAICS for convening us for this health summit. And if there are any closing thoughts from any of our panelists, please let me know.
Thank you.
Okay.
Yeah, thank you. I just wanted to add, I just love the energy of this panel. I think it's so nice to be with a group of like-minded individuals that care so much clearly about our respective communities and then our AA and HPI communities as a whole. And I just think that educating our communities and the collaboration we mentioned between our groups, I think that's going to be the key moving forward, especially, in this political atmosphere. We need to take care of ourselves and look out for each other right now. So thank you all for doing the work.
Thank you. We are the small group of committed people that will change the world. So thank you for fighting the good fight, everyone. Thank you.